Hello everybody. This presentation covers the ABA keywords from the 2023 ITE exam. More specifically, each keyword in this presentation is a topic that our residents did worse than the 50th percentile nationally. Now in general, most folks did extremely well in this exam. I'm very proud of all of you. But there are always bits of room for improvement, and some of these keywords represent some of those. So watch, listen to a little bit about some of these important keywords, and enjoy. All right, the categories are loosely broken into 5 different subcategories. So they are the basic science, clinical sciences, organ-based basic and clinical science, clinical subspecialties, and special problems or issues in anesthesia. We have keywords from each of these 5 subspecialties, so we'll start with our first keyword. All right, the first keyword we have is central line placement and chest x-ray landmarks. So as you know, the gold standard for placement of a central line is to get a chest x-ray afterwards in order to make sure that the line is in the venous system. On a chest x-ray, we can use different landmarks to determine if the tip of the catheter is located in the right spot. So we want the tip of the catheter to be outside of the pericardium, and the pericardial reflection is often easily able to be seen on a chest x-ray. It is often below the level of the carina that's circled there in red, and so therefore an easy landmark is to make sure that the tip of the catheter is at or above the carina. Sometimes folks will often make reference to different rib levels. The tip of the central venous line should be at or above the 3rd rib. But in general, it should be outside of the pericardial sac, which is at or above the level of the carina. Right, our next keyword topic is similar to the last. It is confirmation of IJ cannulation. So after we place a line, we have to make sure that the line is in the venous system rather than the arterial system. When lines are placed in the carotid artery or another one of the major arteries, major complications such as stroke, hematoma, leading to airway compromise, and ultimately death can occur if we use these lines that are in the arterial system. So there are a couple of different ways that we can confirm this before we use the line. The most common is transducing a pressure. So rather than putting the final device in, after we access the vein, we can put in a smaller catheter, and as the picture on the right hand side of the slide here shows, the person who puts the catheter in takes up a column of blood, and if the column of blood slowly falls back down into the catheter, we can safely assume that the catheter is in the venous system. In a similar way, we can connect an arterial line setup to the catheter in the central vein and make sure that there's no pulsatile waveform associated with that. We can also look with an ultrasound to make sure that the guide wire sits in the intended vein. And then, of course, after line placement, the gold standard before use is chest x-ray, although these first 2 methods are often adequate to use lines. As you know, most of the lines that we place either in the holding area or intraoperatively we use before getting a chest x-ray because we use either one or both of these methods to make sure that the line is in the venous system. All right, our next keyword topic is cardiopulmonary bypass temperature monitoring. So as you all know who have gone through cardiac, hypothermia is employed while on cardiopulmonary bypass. Now, due to shifting heat through the different compartments, different sites of measurement, we can get different temperatures. So loosely categorized, there are 3 areas that we can measure body temperature. There's blood temperature, core temperature, and shell temperature. Now, blood temperature most closely approximates brain temperature, which is important because cooling during cardiopulmonary bypass is a neuroprotective technique. So there's a thermistor that measures blood temperature at the tip of the PA catheter, and this most closely estimates brain temperature. There are three other areas to measure core temperature. Those are the nasopharynx, the esophagus, and the tympanic membrane. Now, each one of these sites is closely associated with arterial blood supply, and core temperature closely estimates other target organs, and often these areas are used to determine whether we have rewarmed properly. Shell temperature is the last. This usually lags behind core temperature when we rewarm due to the shifting of heat from the core to the periphery. This is most often done in the bladder, although we have to make sure that there's adequate urine output in order to reliably use this temperature. All right, our next keyword is TEG interpretation. So, this is a topic that comes up over and over and over again. It's a very useful test to determine which blood products can help our patient the most based on their coagulation profile. So there are a couple of key points that we all need to know based on this tracing. So the first part of the tracing that we need to know about is on the very left in red. It's called the reaction time. This is the amount of time that it takes a clot to begin forming from a baseline to up until 2 millimeters of amplitude. Now, the most important part of this reaction time are the clotting factors, because the factors are what initiate the clotting cascade. If there's a prolonged reaction time, this can be treated with fresh frozen plasma. The next key part of the TEG is the alpha angle. This is the angle of the rise of the TEG that goes from 2 millimeters of amplitude to 20 millimeters of amplitude. If the alpha angle is flattened, this can often be due to hypofibrinogenemia and can be treated with cryoprecipitate. In the same way, the clot formation time, or K, is the amount of time that it takes the tracing to rise from 2 millimeters to 20 millimeters of amplitude. A slow clot formation time will lead to a lower alpha angle, and in the same way, this can be treated with cryoprecipitate because hypofibrinogenemia is the cause. Moving to the right, the next value is the maximum amplitude of the clot. This is a measure of clot strength, and it is due to platelets. Low maximum amplitude can be due to either thrombocytopenia or dysfunctional platelets, and therefore it can be treated. A low maximum amplitude can be treated with platelet transfusion, or sometimes DDAVP if there's an adequate number of platelets, but those platelets are dysfunctional. The very back end of the TEG tracing on the right is the lysis index. This essentially is a measure of clot breakdown. Rapid clot breakdown implies that the hyperfibrinolysis, and this can be treated with tranexamic acid or Amicar. All right, the next keyword that we have here is probably from the basic realm. It is triggers of mechanical ventilation. Now, machines are programmed to give breaths based on something called a trigger. There are three main triggers that we have. They are time, pressure, and flow. Time triggers are controlled breaths, whereas both pressure triggers and flow triggers are assisted breaths. So with our time trigger, the machine is set to give a breath after a certain amount of time has passed. So with a respiratory rate of 10, the entire respiratory cycle is 6 seconds. So after 6 seconds of not breathing, that will prompt the machine to initiate and give a full breath based on whatever settings we decide. Pressure and flow triggers are a little bit different because they require the patient to first initiate the breath. So with a flow trigger, as we can see on the little graph on the right, when the machine senses that there's a pressure change within the circuit based on the patient effort, the machine will then assist the patient in taking their own breath. We can set this assistance to any level that we'd like, and we can also set the significance of the trigger. Sometimes a bigger trigger will be elected, sometimes a smaller trigger will be elected, but that's a variable that we can set as well. Flow triggers are very much the same, except instead of sensing a change in pressure within the circuit, the machine will sense a change in flow in the circuit. This is usually measured in liters per minute. Whenever the trigger is reached, the machine will then give a set amount of support to the breath. All right, our next keyword has to do with presentation of malignant hyperthermia. Now, loosely, we can break this into early signs and late signs. Our CA1 group, as we were discussing this yesterday, decided that this question was about late signs, particularly with myoglobinuria, although this is a very late sign because, as you know, myoglobinuria requires a significant amount of muscle breakdown to occur. So one of the troubles with malignant hyperthermia at the very beginning is that the early signs are very vague. They can include hypercarbia, tachycardia, and perhaps the most specific sign is trismus or masseter muscle rigidity, although this doesn't necessarily always happen. As you know, tachycardia and hypercarbia can occur for lots of different reasons, which makes early diagnosis of malignant hyperthermia pretty difficult. Now, later signs are what we more classically think of as malignant hyperthermia that include increased temperature, rigid muscles throughout the body, although this doesn't necessarily always happen. We have electrolyte disturbances such as hyperkalemia. We can see arrhythmias as these electrolyte disturbances become more significant. And then, like our question implied, very late sign, we can see myoglobinuria. As there is a tremendous amount of muscle breakdown, our kidneys have trouble handling that load, and we can start to see myoglobin lost in the urine. All right, our next keyword here is IV regional dosing, more commonly known as the Bier block. Now, the question was about the type and volume of local anesthetic that we used. I've highlighted it here. Generally, a large volume, usually 30 to 50 cc's, depending on whether we're blocking the lower extremity or the upper extremity, is used. And very dilute lidocaine, usually 0.5%, is injected. Now, for those of you who have never seen a Bier block, how this block is done is a catheter is placed at the very distal part of the limb, and a double cuff is placed on the proximal portion of the limb. The limb is exsanguinated, first passively by holding it up so that it drains by gravity, and then actively by using an S-mark bandage to squeeze every last little drop of blood out while the axillary artery is being occluded. Once the arm is exsanguinated, the proximal cuff is inflated, and our local anesthetic is injected into the distal catheter. It takes a little bit of time to set up, and since lidocaine is a relatively quick on, quick off local anesthetic, we get a little bit less than an hour of block time. Now, the purpose for the double tourniquet is that after a while, the proximal cuff, which is in the area that will not see local anesthetic, starts to really hurt. So when that happens, when the patient can't tolerate it anymore, the distal cuff is inflated in the area that should theoretically still be numb from the IV local. And then the proximal cuff is deflated, and usually you can get a little bit more time out of the block without tourniquet pain. All right, so we had a couple of keywords on last, local anesthetic systemic toxicity, and we have slides on presentation and treatment as well. So the presentation of last is generally associated with administration of local anesthetic. The most common time that this happens is during peripheral nerve blocks due to the high volume and high concentration of local anesthetic used. Last is a group of central nervous system toxicity characteristics, and it can progress to cardiovascular collapse as well. The first signs and symptoms that we see are generally mild central nervous system characteristics. So we can see numbness around the mouth, we can see ringing in the ears, and we can just have a general feeling of dizziness. As this progresses, more significant central nervous system manifestations can occur, such as seizures, lethargy, and ultimately coma. If the systemic toxicity progresses beyond this, we can then have cardiovascular manifestations. Now, this occurs because the high concentration of local anesthetic will actually block the sodium channels in the conducting system. And so this can lead to delays in conduction, arrhythmias, and if not corrected, ultimately complete cardiovascular collapse. Now, after that, thank goodness that there's a standardized treatment for local anesthetic systemic toxicity. So the first thing that's required is that when you see signs and symptoms, even the very beginnings of neurologic toxicity, it's important to stop the injection and to not inject any further until you investigate what's happening a little more closely. If you do have significant neurologic symptoms, it's important to manage the airway appropriately because hypoxemia, hypercarbia, and acidosis can worsen the effect that the local has on the entire body. The mainstay treatment is lipid emulsion. The dosing of lipid emulsion often comes up on these exams. Initially, we give a 1.5 cc per kilogram bolus, and that's followed by an infusion at 0.5 mLs per kilogram per minute. We can repeat bolus dosing as necessary, and the maximum amount of lipid emulsion that can be given is pretty high, in the realm of 12 to 14 mLs per kilogram total. Now, if we do have to administer cardiac support in the form of ACLS, it's important to know that the doses of epinephrine should be reduced. The heart that is blocked by local anesthetic doesn't respond to epinephrine in quite the same way as a heart that is not blocked by local. So it's important to reduce the amount of epinephrine to approximately 1/10 of the normal dosing. Our normal dosing of codepenephrine is 1 milligram every few minutes, and the dosing of epinephrine for this sort of situation is about 1/10 of that. The recommendation is 1 microgram per kilogram. Now, there are certain risk factors that put patients at higher risk for LAST. There are patient factors, different pharmacologic factors, and then procedural factors that can either put patients at risk or protect them from LAST. So in terms of patient factors, the old and the young are more prone to having systemic toxicity from local. Pregnant patients as well, and folks who have end organ damage in other ways, when the organs that clear local anesthetics are diminished, their function is diminished, there tend to be higher systemic levels of local, and that can lead to higher risk of LAST. different locals or using different locals can put us more at risk for systemic toxicity. The worst of these is bupivacaine. The reason for that is that there's an extremely narrow window between when patients become toxic neurologically and when patients become toxic cardiovascularly. And so this is one of the dangers of using bupivacaine. Other locals that are more short-acting tend not to have as high a risk of toxicity. Other procedural factors also will cause folks to be more prone to this. Ultrasound guidance is a protective factor. By being able to see where the vascular structures are, we're more able to avoid injecting large amounts of local directly intravascularly. Neuraxial techniques are protective from local anesthetic systemic toxicity because we use smaller volumes of local anesthesia. And then based on the site of peripheral blocks, we can be more or less at risk. Intercostal and caudal blocks tend to have higher risk, while sub-Q blocks and brachial plexus blocks tend to be have a lower risk of LAST. All right, our next keyword here is different from the last. We have post-op delirium in the aging. So what this is a period of poor cognition from about 1 day till about 3 days post-op. There are different risk factors for experiencing this. So the more frail patients are, the more at risk they tend to be for post-op delirium. Lower baseline levels of cognition and lower level of total education also put patients at risk. Those who are poorly nourished, those who abuse alcohol regularly, also tend to have more delirium than those who do not. So if delirium does occur, before it occurs rather, pre-op, the most important thing that we can do is to screen patients for and address those who are at highest risk of post-op delirium, that this may be a possible complication from receiving anesthesia. It's important to discuss this both with the patients themselves if they're able to understand, and also with family members. It's important to have a good plan for pain management, as this is a big risk factor for being delirious post-op. And it's important that the nutritional status be as optimized as possible. Longer fasting periods tend to lead to more delirium. Intraoperatively, we can attempt to spare opioids as much as possible, which have been linked to post-op delirium. Our pain management techniques can be multimodal to help reduce that amount of opioid. Avoiding medicines such as scopolamine, benzodiazepines, and other medications which tend to make patients a little foggy should be avoided. And maintaining an appropriate temperature as well helps people avoid delirium. Post-op, if we see delirium start to occur, it's important to reorient our patients as much as possible. It's impossible to put them in an environment where they're able to sleep at night and be awake during the day. And it's important to talk with them as much as possible and give them exercises to help exercise their brains as well as the rest of their bodies. All right, shifting gears a little bit, our next key word is measured versus calculated ABG values. So as you know, some values that we see on ABG results are directly measured, while others are calculated based on the measured values. So our measured components are pH, PaO2, and PaCO2. Each one of these is measured by a different type of electrode, which sometimes they like to bring up on tests. The Clark electrode is what measures PO2, Severinghus electrodes measure PCO2, and Sands electrodes measure pH. Calculated values that we see on ABG include bicarbonate. They also include base excess or deficit. SaO2 sometimes is a calculated value, sometimes is a measured value. When we use co-oximetry, this is when it is measured. So this keyword is manifestations of acute liver failure. Now, lectures upon lectures upon lectures could be given on this topic, but I'll try to keep it as short as possible. I'm not certain what the question on the ITE was based on this keyword topic, but we'll go through some of the very basics here. So liver failure can be broken into liver damage versus liver function. So liver damage we can gauge by elevations in AST, ALT, and alkaline phosphatase. This doesn't necessarily imply liver dysfunction, however. The best measure of liver dysfunction is by PT and INR rising rapidly. Now, this is due to the fact that the liver produces factor 11, which has a relatively short half-life of only a few hours. So after there's a functional insult to the liver, when INR increases, this can happen fairly rapidly. Signs of hepatic encephalopathy can also imply liver dysfunction. Some of these are just generalized confusion to seizures. Asterixis is a flapping sort of tremor, and some patients can be seen to have hyperreflexia as well. Our next slide shows a few more systemic manifestations of acute liver failure. So we see here that a great many organ systems are affected when the liver fails. So we talked a little bit about hepatic encephalopathy on the last slide. And other organ systems can be affected as well when the liver begins to fail, and these are later signs of liver failure, although some can be seen acutely as well. The kidneys can be affected by hepatorenal syndrome. We can also see electrolyte abnormalities and such as well. The heart can be affected because SVR is decreased dramatically in acute liver failure, and the heart can be challenged because of the high cardiac output state. The lungs can be affected due to hepatopulmonary syndrome and formation of AVMs in the lungs, which leads to a great amount of shunting and ultimately hypoxemia. As acute liver failure turns into chronic liver failure in regard to the lungs, we can see portopulmonary hypertension, which is the hypertrophy of the pulmonary vasculature, which can lead to right heart failure and hypoxemia as well. All right, so this next keyword is beta-2 adrenergic receptor activation. Now, when I went through this lecture the other day with our CA1 class, they weren't exactly certain what the question was getting at here, so I put a little bit of information about the entire beta-2 adrenergic receptor pathway. The most important most important system where the beta-2 receptors come into play is in the pulmonary system. So all of lots of our inhaled medications, such as albuterol, activate beta-2 adrenergic receptors, which leads to bronchodilation. The pathway is such so that stimulatory G-coupled proteins increase the amount of intracellular CAMP, which leads to an increase in protein kinase A, which ultimately causes calcium to leave cells, which leads to smooth muscle relaxation. I'm not sure if the board went into that sort of detail, but ultimately the main idea is that our inhaled medicines activate beta-2 adrenergic receptors, which leads to bronchodilation. All right, our our next keyword here is damage-controlled resuscitation and medications that are used in such a resuscitation. So what damage-controlled resuscitation is, essentially is a whole group of different strategies used to address what's called the lethal triad. The lethal triad consists of coagulopathy, acidosis, and hypothermia, which all make the other two worse and ultimately worsen the outcome when sort of the swirling drain, so to speak, is not interrupted. So there are different treatment strategies to address each one of these three portions of the lethal triad. The most important, perhaps, is resuscitation itself, blood. The idea that we replace blood with blood and avoid as much crystalloid as possible, which ultimately can lead to more hypothermia, more acidosis, and dilute all of our factors out, leading to more coagulopathy. It's important to give blood as in a ratio that's as close to 1 to 1 to 1 as possible. Some studies have shown that whole blood is actually more effective in a damage control sort of setting, although this isn't necessarily available to us. And as we discussed earlier in this lecture, using TEG to guide our therapy can sometimes help as well. What the question may have been addressing on the ITE this year was that TXA, tranexamic acid, is often used as well to try and treat the clot breakdown on the back end of the TEG. It's also been studied and shown that allowing a low degree of hypotension can also help. Lower blood pressures will often lead to less bleeding while surgical control is being obtained. If worst comes to worse and the surgeons are unable to get good control, there are balloon devices that can be placed into the aorta and inflated, which is essentially an endovascular aortic clamp. They can be inflated for a short period of time while control is gained surgically, and this will also help us as anesthesia catch up on the resuscitation. All right, our next keyword topic here is the hepatic artery buffer response system. One of the CA1s in the group was challenging me as to why this was relevant, but it's one of those things that the board feels that is necessary. So if for no other reason, we have to know about it so that we can all pass our boards. So in general, we know that the liver has a dual blood supply in the form of the hepatic artery and the portal vein. The portal vein provides the majority of blood flow, about 75%, but only about 50% of oxygen goes to the liver from the portal vein. The other 50% of oxygen comes from the hepatic artery, though only about 25% of the flow comes from the hepatic artery. Now, flow through these two vessels is controlled by this hepatic artery buffer response. How this works is that in states where there's low portal vein flow, adenosine accumulates, and as adenosine accumulates, this functions as a vasodilator and dilates the hepatic artery. Conversely, when the hepatic portal vein flow is high, adenosine is washed out. Less adenosine means less vasodilation, so the hepatic arterial system becomes constricted, and this way a balance is created between the two systems. The maximum effect is known to be approximately doubling hepatic artery blood flow. So this is a pretty dramatic buffer system. And of course, when the liver is damaged, this system is damaged as well. All right, our next keyword is a fairly straightforward one. It is EKG changes seen with hypercalcemia. So a picture's worth 1,000 words. Here on top, we see that in states of low calcium, we see a shortened QT interval. When there are states of high calcium, hypercalcemia, the myocardium and the conducting system becomes more excitable, and the QT interval is shortened. Our next keyword topic here is lung zones and the effect that PEEP has on these lung zones. So what PEEP stands for is positive end expiratory pressure, as you all know. And this illustration over here to the right describes the zones of West. Zone 1 is a zone where the alveolar pressure is higher than both the arterial pressure and the venous pressure. This results in a relative dead space. Zone 2 is an area where the arterial pressure is greater than the alveolar pressure, which is greater than the venous pressure. This portion of lung participates in gas exchange. Zone 3 is an area where the arterial pressure and venous pressure are both greater than the alveolar pressure, and this represents an area of relative shunt. As we apply PEEP to the lung, that increases the pressure in the alveolus, and it tends to raise the zones. Zone 2 turns into more zone 1, zone 3 turns more into zone 2, and then portions of lung with completely collapsed alveoli can be stented open and turned into both zones 3 and 2, which enables them to participate more in gas exchange. All right, our next keyword, I can't say that I'm too surprised to find on our list. It is neostigmine side effects. In the age of Sugamidex, we are using much less neostigmine for reversal of neuromuscular blockade. So it's not too surprising to me that to find that we've kind of brushed over some of the effects that we can have from neostigmine. So what neostigmine is an anticholinesterase. It increases the amount of acetylcholine in the neuromuscular junction. That is how it exerts its cholinergic effects. But it also has other muscarinic side effects, which are usually things that don't go along very well with what we're trying to accomplish from an anesthetic point of view. A good mnemonic for this is dumbbells. And these include diarrhea, urination, meiosis, which is constricting of the pupil, bradycardia, bronchospasm, both none of us have ever liked bradycardia or bronchospasm before, emesis, lacrimation, and then increased secretions in general, which make our lives more difficult. So these are things when we do use neostigmine, if for whatever reason we're not using Sugamidex, to watch out for. All right, our next keyword here is Pheochromocytoma Diagnosis. Most of the diagnosis of Pheo is done in two ways, through urinary tests as well as imaging. There are a couple of urinary markers that we find, vanillomandelic acid, which has the highest specificity for Pheo, metanephrines, and then catecholamines as well we can find in urine at higher than normal concentrations. CT of the abdomen, a standard CT abdomen, has the highest sensitivity for detecting pheochromocytoma. And then, of course, there are other clinical signs and symptoms that we should watch out for before making a final diagnosis. Patients with Pheo are especially prone to orthostatic hypotension. This comes because with the paroxysmal hypertension that patients experience, they become relatively intravascularly depleted, and most patients with a significant Pheo will experience orthostatic hypotension. One thing that I noted that was sort of interesting is one paper mentioned that a highly specific sign is experiencing arrhythmias with an abdominal exam. So when physically manipulating the tumor, high levels of catecholamine are secreted and can make our patients more prone to arrhythmia in this way. Pheochromocytoma can also be part of MEN2A. That goes along with medullary thyroid cancer as well as parathyroid adenomas. So this can be part of a grouping of diseases as well. All right, pituitary hormone effects. Before you can answer any question about the pituitary hormones, you have to know which hormones are secreted from the pituitary from where. Both the anterior pituitary and posterior pituitary will secrete different hormones. So the posterior pituitary secretes two main hormones, that is oxytocin and vasopressin, while the anterior pituitary secretes six. Those are growth hormone, prolactin, LSH and FSH, ACTH, and TSH. So hypersecretion of each one of these hormones can lead to different clinical presentations. So with hyperprolactinemia, often seen in functional pituitary tumors, we can see hypogonadism in males and females. With increased secretion of ACTH and cortisol, we can see symptoms of Cushing's disease. With increased growth hormone secretion, children, we can see gigantism or acromegaly, which they all have their own implications when it comes to administering anesthesia. With the gonadotroph adenomas, which leads to increased FSH and or LH, we can in females you can find irregular menstruation. Males you can find low testosterone, low libido, or difficulty with reproduction. Thyrotroph adenomas, which tend to be a little bit rare. We can see increased secretion of TSH and T4, which lead to hyperthyroidism and all of the manifestations of hyperthyroidism. This keyword here is sources of physiologic shunt. Now there are two main types of shunts, physiologic shunts and anatomic shunts. Physiologic shunts tend to imply areas of non-ventilated alveoli that are still perfused, such as is seen in pneumonia, ARDS, pulmonary edema, etc. And anatomic shunts are usually thought to considered to be due to structures that cause passage of deoxygenated blood from the right side to the left, bypassing the lungs. Now, two of these areas are the Thebesian vessels and the bronchial vessels. The CA1 class helped me to remember the question that was asked about the amount of shunting that occurs through the various structures, and they wanted you to compare the Thebesian vessels, the bronchial vessels, and they said the third answer choice was something that was sort of irrelevant. With a little bit of research, we found one paper that mentioned that the shunting through the Thebesian vessels was quote-unquote piddling, and the shunting through the bronchial veins was a bit more significant. This is probably true because most of the blood that comes from the coronaries after going to the heart muscle itself empties into the coronary sinus, which then empties into the right side of the heart, which then goes through the lungs. The Thebesian vessels empty into the left side of the circulation. Of course, there are other areas of anatomic shunt as well. We see them in hepatopulmonary syndrome, the AVMs that can develop, and then intracardiac shunting through different defects that remain open, including ASDs, VSDs, and PDAs. All right, our next keyword topic is infection risk after needle stick. So there are three main diseases that are most concerning after needle stick. They are HIV, HCV, and HBV. Now these are listed in reverse order as to the absolute risk of developing these diseases. So the most common disease to develop after needle stick, that is a patient who was stuck with one of these diseases, and then a healthcare worker who was stuck with the same needle, not previously having these diseases. There's about a 1 in 3 chance or so of developing HBV. That risk goes down significantly in HCV to about 1 in 30, and patient or healthcare workers are least at risk of developing HIV after a needle stick. Now there are some other risk factors that can change these ratios a little bit. If you're stuck with a hollow bore needle as opposed to a non-hollow needle, the risk goes up. If the needle stick is deeper, that risk tends to go up. And then, of course, if the number of infectious particles on the needle is greater, the risk of transmission is higher. So this keyword topic is nerve gas exposure and treatments for nerve gas exposure. It's one of those special topics in anesthesia that gets tested on commonly, although I'm sure the amount of nerve gas exposure that we've all seen is hopefully very minimal. So these gases are in reference to sarin and other organophosphates, which are often seen in fertilizers and other materials such as those, insecticides and things like that used on farms. What organophosphates are very, very strong acetylcholinesterase inhibitors. This increases the amount of acetylcholine at the neuromuscular junction, much like neostigmine, which can lead to cholinergic effects, and then they act also at the postganglionic parasympathetic junctions, which exert muscarinic effects. So how do we handle these exposures? So we first have to manage symptoms, so we can expect bradycardia, an increased amount of secretions, and bronchoconstriction, which are really the three biggest troubles that we would run into with nerve gas exposure. So we manage our ABCs. From a pharmacologic standpoint, we can use atropine to treat bradycardia, and we can also use a drug called pralidoxime to regenerate acetylcholinesterase, which will increase the amount of, decrease the amount of acetylcholine at the neuromuscular junction and at the parasympathetic junctions. This keyword topic is neuraxial opioid mechanism. So opioids exert their effects as mu-opioid receptor agonists, and they do this in the gray matter at the dorsal horn of the spinal cord, as we see on this picture to the right. This question may also have talked about dosing of opioids in the different routes of administration. So, epidural dosing versus spinal dosing with opioids usually is a difference of a factor of 10. So, because the epidural dosing requires moving through more layers, the dose needs to be about 10 times higher than with spinal dosing, where medication is administered directly to the CSF. There also could have been some topics regarding spinal selectivity between lipid-soluble drugs and water-soluble drugs. So lipid-soluble drugs, a good example, is fentanyl. This effect is exerted mostly by systemic absorption after administration, either in the CSF or in the epidural space. This is contrasted with a hydrophilic drug such as morphine that stays in the CSF or epidural space for much longer. Lasts for about 24 hours or so. and the effects are exerted directly on the dorsal horn of the spinal cord rather than through systemic absorption like the lipophilic drugs. Okay, we're coming to our last main keyword topic. This is a special topic in anesthesia that often will come up on boards, and many of us don't see this anymore because it's not as common of a treatment as it used to be. So our topic is electroconvulsive therapy, indications and contraindications. But I'll talk a little bit about what the procedure is and some things to look out for as well. So indications for electroconvulsive therapy include resistant depression, psychosis, and some other off-label uses as well. There are theoretically no absolute contraindications, although there are some conditions where you should really think twice about carrying out electroconvulsive therapy. Pheochromocytoma is nearly an absolute contraindication because the significant sympathetic discharge that occurs after the seizure is instituted, which I'll talk about in a second, can become extremely dangerous with large amount of catecholamine release. For the same reason, unstable coronary artery disease is a relative contraindication. Arrhythmias can be elicited during this treatment, so pre-existing arrhythmias sometimes are contraindicated. And then if the patient has intracranial lesions, this procedure can elevate ICP as the patient seizes. So this is a consideration as well. So what ECT is, electroconvulsive therapy, it is an artificially stimulated seizure which has been shown to help resistant depression. So how this is done, the picture on the right shows the lower extremities of a patient undergoing ECT. How they do this is before anesthesia is administered, a cuff is put on the one lower extremity and inflated. General anesthesia is then induced, and some sort of muscle relaxant is given, either a depolarizing muscle relaxant or a non-depolarizing muscle relaxant. The purpose of the cuff is to prevent the muscle relaxant from traveling all the way to the foot. After the patient is asleep and being ventilated, usually with a bag mask technique, intubation is usually avoided. A seizure is elicited by stimulating different areas of the brain. The foot is monitored. Since no muscle relaxant has made it to the foot, you can see the seizure activity in the foot to make sure that the patient actually is experiencing a seizure, and then the anesthesia is maintained until the seizure resolves, usually for just a few minutes. How the body responds to this initially is when a seizure is, the stimulus is initially given, there's a very strong parasympathetic response. This is due to stimulation of the vagal nerve. Once the seizure begins in earnest, that parasympathetic stimulation goes away and the patient experiences a very strong sympathetic surge. A danger can occur if the impulse to create the seizure doesn't create a seizure, and the parasympathetic response continues on. Patients have experienced asystole in that situation, but that's certainly not the norm. And this is the conclusion of the talk on our gaps in knowledge for the 2023 ITE exam. I hope you got something out of it. Keep studying hard. You guys are doing great, and I know that the CA1's taking the basic will do really, really well, and the CA3's taking the advanced will do well as well. So thank you for listening, and I'll talk to you soon.